خصوصا لو كان الاب استعرض. لكن الابن لما يقارن بابناء جيله، يعني ما اقدرش اقارن الدكتور احمد النسيري بالدكتور عفاف. دكتور عفاف الصار كبير فما اقدرش اقارن برضه، لكن اقارن محمد بابناء جيله. دكتور محمد سويدان head of mood and anxiety unit in Kuwait, assistant professor in psychiatry in Kuwait University, associate professor in psychiatry in the University of Toronto. He will speak about bridging patients and psychiatrists' goals in long-term treatment of schizophrenia. Dr. Mohamed, please.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the very kind introduction. People who don't think I look like my father يسمعون الصوت ويقولون نفس صوت أبوك. طبعا الدكتور سوالي psychodynamic problem الحين because I'm going to lose my training. Attended any of my talks before know that I like quantitative science. I use a lot of statistics in my talks, evidence-based medicine. And what I'm doing today is actually a little bit different because I'm going to be talking about that, certainly, hard science, but also I'm going to use a good amount of qualitative research. And I think qualitative research is something I was trained in. I did a fellowship in medical education, and the study I did in that research was a qualitative study. And until I worked in medical education, I'd never realized the power of qualitative studies. I think those of you who are psychologists in the audience use qualitative studies much more than us psychiatrists. And I think it's a shame that we don't use them more. And I'll show you today how qualitative studies can really inform our clinical practice. And if quantitative research is the meat, really the framework I think is made up by qualitative studies. So I'll talk a bit about that. These are my disclosures. I work definitely with a number of different organizations, and I'm very thankful to them for providing me a platform to speak. Today I won't be speaking about any medications by name. I'm just talking about long-term treatments in schizophrenia, so there is no conflict of interest for specifically this presentation. Now, there's an organization called the World Federation of Mental Health Carers, and they did a survey looking at what is it that that patients and caregivers report as most problematic for them in schizophrenia. And if you look at the rates here, the relationship in terms of the patient, the relationship with others, the inability to work, and the fact that they're hospitalized. So really the functional impairment piece is what bothers people the most. Whereas with caregivers, it's the same thing. It's a disruption to their own lives. It's the sense of well-being. It's a sense of effect on their own physical and mental health. So that's a huge problem. So there's this huge human cost when it comes to schizophrenia when it's not treated. Beyond that, there's a huge economic cost. So if we take it in today's dollars, according to US estimates, I don't think we have these numbers when it comes to money in the Arab world as well. We have rates of prevalence of illness, but good cost data we don't have, because what you need to calculate is indirect and direct costs of care. And in the United States, in today's dollars, schizophrenia yearly, every year, costs $72.2 billion. So to put that into context, that's about 1/5 of the United States defense budget. Okay, so the entire US armed forces, every year, 1/5 of that goes towards one illness. So it's a huge, huge burden for a nation. It's a huge burden for an individual. Now, let's leave that aside for now. We know it's a huge burden, schizophrenia. Let's talk about adherence in general. And the term before adherence, maybe some of you know, what is the term we used to use before adherence? I heard it. Compliance, yes. And the reason we shifted from saying compliance to adherence, because adherence puts more empowerment towards the patient. Compliance in English has the connotation or المعنى إن you're putting, the patient is supposed to comply with something that's being enforced on them. Whereas adherence speaks more to empowerment about the patient. The patient agrees with what they need to do to treat their illness. They take the power into their own hands and they adhere to the steps that would get them better. Now, so non-adherence rates are very high, not just in psychiatry, in all of medicine. So if we look at a disease like hypertension, high blood pressure, about 40% of people do not adhere to the medications that they need to improve. If you look at arthritis, which is something you might say, well, hypertension, the patient doesn't really feel hypertensive until they check their blood pressure. But arthritis, definitely you feel the pain. You would think people who feel the pain would be more adherent to the medication, but in fact they're not. Only 55 to 70% of patients who have arthritis adhere to the medications. So nobody likes to take medications. And I can ask you, and in fact we always say this, and those of you who've ever treated in your psychiatry clinic a doctor or medical students, we know that doctors make the worst patients. I know that doctors make the worst patients because these days, I have seasonal asthma, so I need to, when my sir ghbar, I have to take my puffers prophylactically before I start coughing. And every time I wait till I start coughing, and then I start. And what happens is I cough for 2-3 weeks until the steroid catches up. صح? So all of us, none of us like to take medications. And what are we going to do to improve that? So how do we check that our patient is adhering to the medication or not? And surprisingly, a lot of these steps doctors don't do, whether psychiatrists or medical doctors. So many people don't ask the patient at every visit, are you taking your medication? We just assume that they are, and we re-prescribe. A lot of people don't ask a collateral information giver, like a relative. Is the person taking their medication? Sometimes in centers or programs that have become more advanced, you have actually observation of the taking of medication through something called assertive community treatment or ACT teams, or supervised housing or community dwelling. You can use scales. I don't know how much better that is than asking a patient, but there are scales like the Drug Attitude Inventory, DAI, at least that measures the attitude towards should I take this medication or not. And there's the Medication Adherence Rating Scale, so the MARS. So you can do that and then compare the score visit to visit. You can actually count the patient's pills, and I've done that when we were involved in a clinical trial at Stanford. You would actually count to make sure that the person was taking the pill. Now, of course, they could be throwing it down the toilet, but that's one of the things you can do. And you can measure plasma drug levels, which is best. Now, of course, it's not easy for all drugs. Most drugs have plasma drug levels, but not all of it is clinically relevant. Not everything's lithium or valproic acid. So studies have shown that when you actually measure adherence versus ask about it, there's a huge gap. So these are two different studies in schizophrenia. The one in blue looked at asking the patient, are you adherent to the medication? And almost 70%, 67.5, said, yes, I am. Where you actually count the pills, only 10% of them were. Another study, this was using a very cool technique, and I've seen these devices before. So they look like the normal pill bottles, but actually there's a microchip in the top of the pill bottle. So when you open it, it's called a microelectronic event monitoring device. So when you open it, actually every time it monitors, it was open, and then the assumption is you took one of the pills, and then you close it again. So they asked the clinician, is your patient adherent to the medication? 95% said yes, but according to the monitoring, the electronic monitoring, only 38% were. So that's a huge gap. This is another study showing that over 3 months, patients self-report, about 55% were reporting, yes, I am adherent to the medication. You actually count the pill, you get a 15% gap. Okay? Only 40% actually had the same number of pills that if they were adherent. And the same number that when you count the pills, you actually measure at the blood level, which is the gold standard, and you get another drop, 23%. So 23% of the total after 3 months are actually taking the level of medication which should work for them. In schizophrenia, in Finland, and you know that the Scandinavian countries have some of the best drug registries in the world. And what was shown in Finland, that about 30 days after discharge from hospital in individuals who have schizophrenia, only about 60% even collected their prescription. And 30 days after that, only 45% continued their initial treatment. So it's a huge, huge problem. And the problem is not just in the Arab world, it's in Scandinavia, it's in the US, it's all over. Now, so what influences adherence? And this is my first example of a qualitative research study. So this was done by Kickert, and what he did is he asked individuals, patients, carers, and psychiatrists, what are the biggest influences to you taking the medication regularly? So the number one for patients and carers was, if I feel that the medication is effective, then I will take it regularly. Interesting. And psychiatrists actually rank that as number 5 in their list. It's not even in our ranking here, شايفينه هو below. So psychiatrists assume that the effectiveness doesn't matter much to the patient, whereas more so than side effects in terms of adherence. But actually the patient and the carer is telling us, no, if I feel a medication is effective, then I'm going to take it. And now, you know that feeling that a medication is effective often is psychological, not just biological, and we'll talk about that in a little bit. Psychiatrists believe that the number one thing is insight, but carers and patients actually think, no, it ranks lower. Psychiatrists, and I'm one of them, I used to think, look, side effects is the highest. But patients actually are willing to put up with a lot of side effects, according to this study. They're willing to say, you know what, I'll deal with some side effects. If the medication is very effective, I'm okay with side effects. Maqbool, right? So I think what we need to emphasize is the medication is effective, and then the different things, they don't really match up. But I think that's the biggest insight for me. Look at this difference here. Effectiveness, patients rank at number 1, psychiatrists rank at number 5, psychiatrists rank side effects number 2, patients rank them number 6. So that's a gap that we need to bridge. So why is relapse prevention essential? And a lot of you know this, so let's go through this quickly, showing you some data. There are biological consequences, of course, to frequent relapse. And what happens, and this was shown, is that after every relapse, you get 1 in 6 patients more so do not recover. So at the first episode, you get about 12% not recovering, and then obviously it comes down a bit because people got treatment after the first episode, 8%, and then if they have a third episode, 19% don't recover after that. Fourth episode, 27%, and what do we call this process? Well known in bipolar disorder is kindling, right? Every episode becomes worse, harder to treat, more difficult. Now, if you have an early outcome, and this was a study showing patients that were treated with a long-acting antipsychotic right from the beginning, and they had an assertive monitoring program, you actually found 82% developed response, only 19% had relapse, 60% had full remission, and only 5% were refractory to treatment. So that's a big difference from taking oral medication. Now, the risk of symptom recurrence following a first episode psychosis, weighted over 1 year in terms of recurrence. If you have discontinuation, you have a 77% chance that you're going to relapse in schizophrenia. This is what I call betting against the house, right? For those of you who watch movies like The Godfather and Casino and Scarface and this genre of movies, they always say, don't bet against the house, because the house always wins, right? Schizophrenia is the house in this case. Don't bet against the house is going to win. Whereas, the number is removed here, but it's over 90%. If you're continuing on the treatment, you have less than a 10% relapse rate, over a 90% non-relapse rate. So continuation is key, especially after the first episode. You want to prevent relapse as much as possible. Let's summarize all this, giving you little flashpoints from different studies that were included in these systematic reviews. So Morgan in 2008 showed that 1 week of non-adherence in 2 years increased the relapse rate from 18 to almost 70%. 1 week of non-adherence. Wyden showed something that a gap of as short as 1 day to 10 days increased the risk of hospitalization by 2-fold. Right? Because really it's the tip of the iceberg, right? If you have a person not adhering for 1 day, there's probably 1 day hni, 1 day hnak, asbu'a hni, asbu'a hnak. It's the tip of the iceberg. It's like the Titanic, right? The Titanic didn't see the iceberg. It was a little kind of thing. Came up next to it, biggest ship in the world, sank. And this is what's going to happen. These 1-2 days are the tip of the iceberg. The patient's going to sink if we don't pay attention to them. Herring showed that a 30-day gap was associated with a 40-time risk of what? Of suicide. Right? So the most, scary outcome we can have in our field. Beyond this, let's say that someone was non-adherent and then they went back to being adherent. The secondary response after you were already non-adherent becomes less. So not only do you have more episodes if you relapse frequently, also you become harder to treat. So this showed that on average, if you have a relapse after the initial phase, your score on the PANSS is 2.2 higher, total score, even 8 months later, even after going on the same treatment, at the same dose, because of that initial relapse. So that's a problem. And you get higher rates of treatment refractoriness, right? So from all aspects, it's a problem. In the term of recurrence, in the term of response to medication, in the terms of refractoriness, and in terms of real human outcomes, whether it's economics, whether it's loss of life, whether it's burden on caregivers. So these are biological consequences, psychological consequences. We talked about all of these, and of course it increases stigma. So let's move on to treatment. So what are the goals of treatment? Well, another qualitative study, asking the patient, asking carers, and asking psychiatrists. What is the goal of treatment? For patients, number one, interestingly, and we're talking about schizophrenia, it's having fewer depressive thoughts and feelings. And I remember one of my professors, this is an older guy in Canada, telling me, you know, what we've done a good job as scientists and in this field of treating schizophrenia is we've done a good job at treating the symptoms that bother us as society. Because the symptoms that bother us is when a patient is talking to themselves or responding to hallucinations. And in fact, you talk to some patients, not all of them of course, but some patients, not all hallucinations are unpleasant. But depressive symptoms are always unpleasant. Negative symptoms are always unpleasant. Cognitive delay is always unpleasant, right? What we've done a good job as, and I'm قاعد نسوي جلد الذات شوية, but as a scientific community, is we've done a good job at removing the auditory hallucinations and maybe the delusions. And that's good. But that's not what's most important to the patient. They want to be a part of day-to-day life, and they're willing to put up with a little bit of delusion, a little bit of hallucination, if they can have less negative symptoms, less depressive symptoms. For carers, fewer depressive symptoms was ranked low. Again, society is bothered more by the positive symptoms. And in psychiatrists, again, number three, what do carers provide? Less disease-related symptoms. We're talking about more the positive symptoms, hallucinations, delusions. And for patients, that was actually number 5. And for doctors, it was high, number 2, right? So again, we do a good job at treating the symptoms that we care about, not what the patient cares about. Psychiatrists ranked improved cognitive ability very high. That's lower for carers, that's lower for patients. And then overall treatment satisfaction, reduction of anxiety, kind of. But again, what I want to point out, just like I pointed out in the first study, look at this, look how low it's rated. So that's another bridge that we need to build over this gap. Now, so what is the current role of long-acting injectable antipsychotics? The guidelines tell us that they should be used and they should be considered for anyone who has frequent relapses or non-adherence. Yes. So frequent relapses or non-adherence, we need to use them. Okay? So that's the key. The beginning of that sentence is key to me. It's not just someone who's non-adherent. Often we think long-acting injection, you're non-adherent. No. If you're having a lot of relapses, assume non-adherence. Because you saw the studies showing non-adherence. And it's very hard to detect unless you're doing the gold standard plasma levels, right? So assume non-adherence if someone's relapsing a lot. Now, what do healthcare providers believe about long-acting injectables? When should we start them? Now, this is a study looking at patients. This is a retrospective cohort looking back at patients who started a long-acting injectable within the first 5 years of their illness versus those who started 5 years after their illness began. And what's shown in this study is that those who started a long-acting injectable had a longer time to discontinuation over the long run. They had a greater improvement in the long run in their validated scores for psychosis, the PANSS scores. They had a longer time to relapse. They had higher remission rates, and they had greater improvement overall in the BPRS, the psychotic rating scale, right? So in all measures, they're doing better if you're starting a long-acting injectable early. Does that mean everyone has to be a long-acting injectable early? Of course not. But what we're saying is, if you have someone who's relapsing a lot, don't wait, because you saw the consequences of waiting. Every episode becomes harder and harder to treat. Now, this is the last qualitative study I want to show you, and it's a plausibility check. Let me just explain this study to you. What they did was they interviewed doctors and patients in dyads. And so it's doctor, patient, the doctor being treated, the doctor treating the patient. And what they did, this is 136 patients and the psychiatrist, and they're interviewing both, and looking at the same time what the doctor is saying and what the patient is saying about a long-acting injectable. So the first thing is, the doctor's saying the patient didn't go on a long-acting injectable because they have good adherence to an oral drug. But at the same time, those same doctors were saying that 14 of those patients, 31%, were non-adherent at the time of admission. Right? So أنت قاعد تقول إن this person's going to adhere, but they were admitted for non-adherence. Right? So we kind of just skip over that in our minds. And then the other part, 18% of those patients were assumed to راح يكمل يكون non-adherent بعد ما يطلع من المستشفى. Those same patients that we're saying has a good response to an oral drug. So that's point number one. It's not plausible. Point number two, the doctor is saying, these patients refuse a long-acting injectable for 23 patients. Those same patients, those 23 patients, when you interview them, almost 50% of them says, my doctor never talked to me about a long-acting injectable. The doctor is saying the patient refuses. The patient says, no one talked to me about it. Now, about 9% of them said I would accept, and I think that number would be higher if we even talked to them about it. So that's a plausibility check. Third point, the patient's antipsychotic is not available as a long-acting injectable. This is the doctor saying, for 38 patients. And in fact, 29% of those 38 patients, the antipsychotic they were on is available as a long-acting injectable. So that's a lack of knowledge. And then this last point is, I do not use long-acting injectables for my first episode patients, whereas you're assuming that they're non-adherent in the first place, right? So if you're assuming they're going to be non-adherent, why wait? You might wait the first episode, but why wait more than a second episode? So let's wrap up because the time is done. Non-adherence really comes down to what is called an invisible epidemic. It reminds me of, have any of you heard of the dark field study by NASA? Anyone heard of it? The dark field study? So everyone knows there's a Hubble Space Telescope, right? Yeah, you've heard of it. Tarek is one of my favorite speakers because I always learn from him because he reads day and night and he's a night owl or a night bat. And so I was sure someone was going to raise their hand. Akid, it would be Professor Tarek. So the dark field study or the deep field study is NASA took the Hubble Space Telescope and it's spinning around the Earth and they said, hey, what's in that black space over there in between the stars? Is there anything? And so what they did is they aimed it at one patch of the night sky and they focused on it for about 20 minutes. And every time the Hubble telescope would come around the Earth, they would focus on that spot. And they did this 400 times, focusing on that one spot in the sky. And then the image they got blew their minds. Because when they zoomed in and they zoomed in, what did they find in that dark place in the universe? They found 100 million galaxies. Okay? So, it's not all black. That's what we call something that's an invisible epidemic. You don't see it, but it's huge. And I think that's the problem with non-adherence. We don't see it, but it's a huge problem. And it's been estimated to be at least 40%. Let's summarize with this statement from Haynes and McDonald in a study. They said, it has been suggested that increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than any improvement in specific medical treatments. Yani it's better to get them to adhere than to create a new medication that's more effective. That's the estimate. So let's finalize. First of all, when you give a long-acting injectable, antipsychotic, and in the second generation we only have a few. We have risperidone consta, we have Abilify Maintena, and we have Invega Sustenna. So those are the three long-acting injectables available from the second generation. And of course all of you know the first generation. So the nice thing with those is that you get an early warning sign. If the patient does not come for their injection, that's an early warning sign that they're not adherent. It gives you weeks to react. The patient's majal appointment, the pharmacokinetic curves are still there, right? Because the injectable is going to drop off slowly. So you have time to catch them and give them the injection. It gives you an opportunity when they come in for their injection to provide psychosocial support. You have more predictable plasma levels, you have better efficacy. In fact, in the long term, in the beginning, a lot of people have more side effects, but in the long term, most people have less side effects on long-acting injectables, especially the second generation. There's less of a risk for overdose on medication, right? Because they don't have the injection. And lastly, a lot of patients prefer it because it doesn't remind them of their illness all the time. Of course, there's things beyond the biological treatments like CBT, like psychoeducation, and the key word for psychoeducation is empowering the patient, and a lot of other non-biological interventions. So pharmacology plus the psychosocial together gives you adherence. Thank you very much for your attention.
Thank you, Dr. Mohamed, very much. I think we can say it was our inshallah.
يعني ما عندي psychodynamic conflict.
أنا قلت أنت هتقول لن أعيش في جلباب أبي لكن it sounds that you are living in the same top. Okay, we have opportunity for only one question because the time is over. Okay, please don't.
Just my questions, the biological treatment is more, has emphasis on the Western countries.
Yes.
And therefore the absence, the WHO study that was being done in various areas and come out that the outcome, the psychosocial intervention plus the biological is better in India than in America. And it's vice versa for treatment of cancer. If you have a chance, if you have schizophrenia, you better live in India because of psychosocial support that's absent in the Western country.
Yeah.
Therefore, the studies focus more on biological and we need to emphasize on psychosocial.
Yeah. It's a very good point, though, and I've heard these comments before. The only thing I would comment here is that you have to look at it both ways when you look at culture. Often when we as psychiatrists or scientists, we look at culture, we look at it one way, from families and care providers. And we don't look at it from the perspective of the patient. You have to remember that patients in North America are brought up in a culture where independence is highly, highly valued, right? So I think it's not just about less psychosocial support, which may be true in Western countries, but actually patients tend to want to be more independent in the Western world because independence is very emphasized. It's part of the DNA, the cultural DNA, to be very independent. Whereas Eastern cultures, the DNA is that you're interdependent, that you're interconnected as families. And so it's very complex to pick apart. But thank you, it's a very good comment. Maybe the last comment I'll make is I'm very pleased. This is my first psychiatric talk in Jeddah. And I called my wife and said I'm speaking in Jeddah, and my wife is from Jeddah. My wife's Saudi, I'm in Jeddah. And she said, you're giving a talk now? It's 9:30, 10. Have you ever given a talk that late? قلت لها no. قالت كل شيء بجدة يبدي متأخر. تذكر عرسنا ما تنزل العروسة إلا الساعة 12. Those of you who are not from Jeddah, I had my wedding here. The weddings here start very late. The bride doesn't come down till 1 a.m., 2 a.m. And so I had to take coffee just to stay up for my wedding. So maybe you need to do this for the conferences. Just have coffee for the non-Jeddah people.
Okay, thank you, Dr. Mohamed. Please.